Hey everyone, welcome to End of Life University podcast, where we share real talk about life and death. I'm your host, Dr. Karen Wyatt. Thanks for joining me here. This is episode number 288, and I'll be sharing with you an interview I did with Dr. Naheed Dosani, who has created a palliative care program for homeless people on the streets and in shelters of Toronto, and I just can't wait to share our conversation with you. I'm really excited about this project he's doing, and I want to share it with you because I would love to see this spread everywhere. I'd love to see lots of communities taking on a project like this, providing palliative care and hospice care for homeless people who are living on our streets. So in just a moment, we'll get to that interview. But first, a quick reminder that the rescheduled webinar on laughter yoga with Janet Carroll is coming up on March 10th, Wednesday, March 10th. And you can register for it. It's a Zoom link you can register for, which I will leave in the show notes for this episode at eolupodcast.com. So come and join us. It's not a comedy show. It's actually a laughter exercise where we learn how to laugh even when there isn't something funny happening around us. So we learn how to use laughter as a tool, and I'm really looking forward to that, and I think it's something we all can really use right now. So stay tuned for that webinar. Also, a quick thank you to all my Patreon supporters out there. I really appreciate you. You keep me going from week to week. So thanks for your ongoing donations to keep the podcast on the air. Now we'll go ahead and I'll play this interview with you because I'm so excited to get right into it and share it with you. And as always, stay tuned afterwards and I'll come back with a few takeaways and to say goodbye. So here we go. Today, I am so excited to introduce my guest, Dr. Naheed Dosani. Dr. Dosani is a palliative care physician and health and human rights activist who is dedicated to advancing equitable access to health care for people experiencing homelessness. He developed Palliative Education and Care for the Homeless, or PEACH, a program of the Inner City Health Associates in Toronto. This model of care has inspired similar programs in other cities across the continent and the development of Journey Home Hospice, Toronto's first hospice for the homeless, which opened in May 2018. Dr. Dosani has received many prestigious honors for his trailblazing work. He's been featured on lots of other podcasts and news programs. And so for me, it's a huge honor to have him here. So Naheed, thanks for joining me and welcome.
Thank you so much for having me on, Karen. I really appreciate it.
Well, when I first read about your work with the homeless, I was so excited and felt like I was hearing about a kindred spirit because I've been a hospice doctor during my career, but also had a lot of interest in working with the homeless. And so I've really been looking forward to this chance to get to know you better and to find out, to begin with, what inspired you to go into palliative care and also to work with homeless people.
Yeah, I was born and raised in Scarborough, Ontario, and I was I'm the son of two refugee parents who came to Canada in the 1970s due to a crisis happening in their home country, Uganda. That meant I would grow up in a home that was really focused on, the social determinants of health. There was a huge emphasis on what migration means to people, on the struggle, on poverty, and always knew I wanted to use my work to focus on dismantling structures of inequities in our communities. And I found that, through healthcare, that was a great way to do that. There are many ways to do that, and healthcare just seemed to resonate. But I never really knew what palliative care was. It was only until I got into my residency program when I actually got into a situation where I was providing healthcare for a program for men who were experiencing homelessness. And I met a gentleman named Terry who presented to our shelter in pain crisis, and he was really in a very difficult situation, and he had a long-term diagnosis of schizophrenia. He was a drug user, a person who used drugs on the streets, and had this widespread head and neck cancer, and he presented in pain crisis in our shelter. And I got to get to know him and connect with him, and I realized he was lacking access to palliative care and quality of life medications like pain medicines that would help him. I began to build a rapport with him, and despite my attempts to build a relationship with him, he ended up dying through an overdose of combination of alcohol and street drugs. And his friends say that his pain management was so poor that he turned to alcohol and street drugs to treat himself, and he died in my care. It was then that I realized that many people in our communities lack access to palliative care, and particularly people who experience homelessness in our communities.
Wow, it's so true. And, I myself just became more aware of this issue a couple of years ago when I was visiting a big city, just walking down the street, and a man collapsed on the sidewalk in front of me. And he was obviously homeless, carrying his things with him, but he had a hospital bracelet on and was carrying a bag of medications. And he had just been discharged from the hospital. And he said he'd been there, been diagnosed with cancer. They told him there was nothing they could do. And they sent him out in a taxi that just dropped him off on the street. And he was obviously in terrible shape. There's no way this person should have been discharged from the hospital and should be lying on the street alone in the condition he was in. But I felt so helpless as, a hospice doctor. I wanted to help him so much, but I had no idea what to do. And so when I heard about Peach and the fact that you've established a program to help people like this, it made my heart sing, because I see now the need in a way I may not have recognized it before had I not encountered that man on the street. So tell us a little bit about what Peach is and how it got started.
It's really interesting that you say that, Karen, because recognizing the intense pressures our hospital systems are under, you would never, discharge someone to the street if they didn't have medications, for example, or, you would never discharge them without appropriately conducting the investigations that are needed or whatever, right? But we live in a world where it's okay to discharge people without a home to the street, right? And I wonder if that discourse will change over time. And it was this kind of feeling that really inspired me and colleagues that I work with to think about palliative care delivery in a different way. And in 2014, we came together at the Inner City Health Associates in downtown Toronto to inspire a new way of providing healthcare, and particularly palliative care. And that was the development of the PEACH program, Palliative Education and Care for the Homeless. We're a mobile street and shelter-based palliative care program that aims to meet people's needs wherever they're at, on the street, in a shelter, under a bridge, so no person falls through the cracks. So everyone has access to high quality care and palliative care, but also palliative care that is trauma-informed and seeks to support people through a harm reduction approach. And we can talk more about that if you're interested. Over the last 6 years, the program has really flourished and grown. We now care for between 120 to 130 clients at any given time. The team consists of health navigators, nurse coordinators, home care coordinators, a whole home care interdisciplinary team, and our palliative care physicians, and has really grown to meet the growing need in our communities as well.
So you travel to wherever the patients are in order to provide care to them. Do you have like a mobile van you take or something, or does everyone just go on their own to see the patients?
So we are a mobile palliative care unit. That's exactly right, Karen. And we meet people where they're at. In some cases, that means meeting people out in the outdoors, in parks, on street corners. In other instances, it's connecting with shelters and other housing providers or respites and drop-ins. Some people who have experienced homelessness for several years and decades get housing because of their illness, and we then follow them into housing, because we know that just because you have a roof over your head doesn't mean that you've dealt with the trauma of what it's been like to experience homelessness. So we go everywhere. We use we all use our own individual individual vehicles to get around. And that's how we're able to meet people where they're at. It's not just geographically getting to people, but it's also, as you would know, Karen, when you're in someone's space and you've taken that step of getting outside of your clinic or hospital, you're in their space, and it's a way to build trust and rapport with people. And we find that we're able to connect with people who wouldn't otherwise connect with healthcare because we do that.
So how do you find the patients? How do you hear about the people who need your services?
One of the things is that we get about half of our referrals from healthcare workers, emergency departments, hospitals. Many of the discharge planners in our hospitals know and appreciate the PEACH program because it provides an extra layer of support for those clients who are unfortunately going back to the street or a shelter while dealing with a life-limiting disease. But we're really proud because half of our referrals actually come from non-healthcare workers. So we have trained social care workers, housing managers, outreach workers, case managers, and in that whole kind of sector within the homelessness and housing sector to better understand what early palliative care, which I just call timely palliative care, is and the importance of it. So, we get referrals saying, we know this person has gone to the hospital 6 times in the last, 2 weeks. And, these are some notes we receive. We don't know exactly what they mean, but can you come take a look? Or this, we have a client we know he has dementia, but now he's losing weight and falling a lot, and we get called in. And in most times, like 99% of the time, the referrals that come from non-healthcare workers are really appropriate and perfect. And so we're building a community of compassion, a community of practice that better understands the palliative care needs of people experiencing homelessness that way.
So it sounds like that's the education component in the name PEACH, palliative education and care for the homeless. It's educating the service providers out there to recognize when palliative care is appropriate and needed, and even to know that you're there to provide that service.
You're absolutely right. You're so right, Karen. Thank you so much for bringing that up. We focus a lot on the care, and I think that makes sense. But the PEACH acronym, palliative education and care for the homeless, the E comes before the C for a reason, right? So we recognize the importance of education in this, and we would not be able to provide the kind of care that we provide in our communities if we didn't centralize focus our approach around building education and awareness in our community. So education is essential. And by the way, education doesn't mean downloading information on other people. We learn a lot from the communities we serve as well. And I think for too often, the palliative care community has been focused on going into communities who don't have palliative care services and saying, this is how we do things, be like us. And that doesn't work for communities who've experienced trauma. The learning has to be 2 ways. Palliative care has been happening in several communities who have not technically had access to palliative care for decades and years. It's just not the way we normally do it. So the learning is definitely 2 ways, and that's how we have to approach it so we can build relationships.
So I have a couple of operational questions, like how is PEACH funded? So how do you pay for the care that you offer?
Yeah, so the PEACH program is a program of the Inner City Health Associates in Toronto, Ontario, Canada. You can visit our website at www.icha-toronto.ca and then hit programs, and you'll see that PEACH program. Inner City Health Associates is a funded program of the Ministry of Health in the province of Ontario, and then funds kind of flow from there. But it's mostly allocated for physician funding, and what the organization has been able to do over the years is prioritize the use of that funding for interdisciplinary supports like nursing. We recently got a fabulous, incredible gift from the Slate Foundation to fund our health navigator, which is a new role in the team, a social worker on our team whose function is to problem solve, basically deficiencies in the social determinants of health that she notes in our communities. And her name is Leanne. We're really grateful to have her. She works collaboratively with Sasha, our nursing coordinator. And so that's kind of how the program is funded. It is a unique funding structure. And what I've found in communities across Canada and the world that do this work, no 2 organizations are funded in the same way. They're all funded so differently, which makes this so challenging.
Yeah, I can imagine that. It's hard to replicate on that, the operational side of things, because depends on what's available or the laws or the structure of the healthcare system. But as a team, how do you coordinate the care you give? I was just curious about that. Do you have team meetings, or how do you communicate with each other to decide
Yeah.
who's needed where?
Especially in a pandemic where we don't meet in
Yeah.
person as we once would have. It's so important for sure. So the way the program works is we have a caseload in our communities, and each day there's sort of a team assigned to provide care. And basically each physician works on a different day. We also have a peach psychiatrist on our team. So depending on the day, there's a schedule that's sent out, and the physician and or the psychiatrist go out and see the clients on an outreach model. And then what happens is once a week, there's a interdisciplinary kind of table rounds that happens where we work together. Everyone kind of comes together and talks about cases, just to make sure we're all on the same page. Continuity is really important. We try to have the same kind of physicians see the same clients, but sometimes there's an urgent scenario and you have to drop in. And it's nice to work with a colleague who, we practice in very similar ways, and we prioritize communication, both verbal and written, and that's really important as well. And sort of the constants in our program are our health navigator and the nursing coordinator that provide that backbone, so that there's like one constant, because they work full time, to be able to provide the kind of care that's needed for the clients that we support. So it's flexible enough to allow people to work in a way that, they can plug in their hours and see people when they need to, but it's also sort of stringent in a way that allows us to be checking on each other, communicating appropriately, and checking in quite frequently as well.
Yeah, it sounds like you're very, very well organized because you don't just have one hospital ward where you go together to provide the care to people. It's really fascinating. And I was thinking back to the story I was telling about the homeless man who collapsed on the street, and recognizing the discharge planners and the care providers at the hospital must be so relieved to know that you're available, so that when they have someone in the emergency room like that man, they know they're not just sending them out alone, not knowing what will happen to them. To know they can bring your services in, that's got to be a huge relief to them.
Yeah, I think it does give people an opportunity to have a disposition where there probably or possibly wasn't a disposition previously, right? And that's kind of what I'm getting at, in the sense that, to your point, Karen, early on in the story that you told, people are often discharged right to the street, but now people can be discharged to the street with a healthcare team that supports them. Keeping in mind, Karen, that sometimes people want to be discharged to the street, right? Like, we may not want people to be discharged to the street, but there are many people we care for who would rather be in the street than in a hospital, in the absence of housing, right? So it is helpful, but sometimes I wonder on the flip side, are we giving the healthcare system an excuse to discharge people to the street when they shouldn't be, right? And there are times when we push back and say, we know you want to discharge the street, and we know that we're there to help provide care if you discharge this person to the street, but they are too sick and you must keep them and you must work with them to find them housing or transfer their care to a hospice or a palliative care unit. And we do that advocacy too. So it depends on the scenario, but I it's important to talk about that side of things too.
Yes, that's such a good point. And I was wondering, I do feel like to many of us, the homeless population has been somewhat invisible, in spite of the fact that if you live in a city anywhere, you see homeless people on the street. But I almost feel, at least here in the US, as a society, we've been somewhat hardened. We look away, we don't notice them. And I think the medical system has done that as well, has really neglected this group of people, maybe partly out of feeling overwhelmed, like no one knows what to do or how to help. But I don't know, what are your thoughts on that?
Yeah, I think it's important to say that people experiencing homelessness are one of the sickest subpopulations in the world that doesn't get enough exposure and discussion. This is a population that's 28 times more likely to have hepatitis C, 5 times more likely to have heart disease, 4 times more likely to have cancer. When people experiencing homelessness get sick, they're 8 times more likely to present to the emergency department compared to you and I, and 4 times more likely to be admitted to hospital. So they're sicker, and they use acute healthcare systems more. And I think the most wild statistic that many people don't realize is that people experiencing homelessness have an average life expectancy of 34 to 47 years old. 34 to
Wow.
47 years old. Yeah, they die at a rate that's 2.3 to 4 times higher than the average, baseline population that's housed. And it's important to say that we now have many studies that show that people experiencing homelessness, their lifespan is cut by half because of being homeless. Right? So
Wow.
we view homelessness as a terminal diagnosis of the social determinants of health. It is a palliative care diagnosis of the social ailments in our society. Right? And I know that's not how we typically look at things in healthcare, in palliative medicine, right? Or in palliative care, right? But and you may, I'm sure some people are listening and thinking that's kind of odd to say, but it's meant to be thought provoking for a reason. When our peach team meets clients, they already have experienced homelessness, and we know that's already cut several years off their life. Then when you add a life limiting disease, it is like a very dire scenario. So that's how we view things. That's our baseline in these discussions.
Wow, because I was going to ask you, how great is the need for palliative care in this population? But you've already answered that it's huge. And so a huge unmet need in most of our communities.
Absolutely. I mean, I would say that and there are several really great examples of healthcare systems that have been derived to support people experiencing homelessness across North America and around the world. But what I will say, Karen, is that any healthcare system that's been designed to support people experiencing homelessness and doesn't include palliative approaches to care, either through like a mobile program or, beds, for example, is really missing the mark, because sadly, people are so sick, right? And people are at risk of death and dying at a rate that is so high that there's no justice if you're not, deriving palliative care approaches, right? Not to mention that palliative care is so person-centered, it's holistic. I mean, I know you know this, right? But I think it's important to reflect on this, because we're talking about a population that has experienced significant distress, loss, suffering, and trauma in their lives, right? So it's that kind of thing that's really important to talk about.
Yeah. And you mentioned earlier that you do trauma-informed care. So maybe we should talk about that now. If you would explain what that is, and then how you offer that type of care.
Yeah, absolutely. So trauma-informed care is a recognition that people in our communities experience loss, suffering, and trauma at the hands of healthcare and institutions. And trauma-informed care is a way to recognize that and meet people where they're at. It's everything from learning how to pronounce someone's name to referring to them by their appropriate, preferred pronoun, for example, to better designing policies and programming that meet people where they're at. Like the PEACH program, like I would say that that's a trauma-informed clinical care model, right? That delivers palliative care in our communities. I would say any program that better supports people with severe and persistent mental illness is trauma-informed, or, even harm reduction for people who use drugs, something that we don't do enough in palliative care. Trauma-informed care is a way to heal people and support them even when they're sick and dying. And I hope that as time goes on, Karen, these conversations convert from, what is trauma-informed care to how do we actually do trauma-informed care. I think this is really where palliative care needs to go in the next, few years and decades.
And it makes sense in that regard of trauma-informed care when you say some patients would rather be on the streets than be in a hospital, and some might even reject going to a shelter because that's preferred, is that you meet the patient where they're at and you honor whatever it is that they're dealing with and whatever their issues are, instead of trying to force them into some sort of a model or a mold that you see fit for them.
Yeah, and too often we kind of project our thinking of what a good life is on people. And in palliative care, we tend to project what a good death is on people, right? And you got to be really careful of that. And I know that gets talked about a lot in palliative care circles, but especially when supporting people experiencing homelessness, meeting them where they're at, being trauma informed is about not projecting our ideals, values, or goals on people for what we would have wanted if we were in that situation. And so it does break my heart sometimes when people that I care for choose to leave a hospital, for example, or give an example here, and choose to go live life on the street. But it is what people but if it's what the person I care for wants and they understand the full ramifications of that, then we support them, and we support them in the way that makes sense to support them on the street. Obviously, we work to get them off the street and try to work with them in a way that can kind of help them. And once we build trust, we find that actually works out. It's just building the trust and taking the time to get there.
Yeah, that's so interesting because it just reminded me of a patient that I cared for long ago in my hospice days, but he had been homeless most of his life. He was kind of a vagabond who rode trains around the country. So he'd lived in many different places, just riding trains from here to there. And we were caring for him in our hospice kind of as a charitable case. And we were able to get a little dingy apartment for him to be in as shelter as he was dying. And I visited him the day he died. I visited him that morning, and I wanted to just stay with him or bring in a volunteer or someone to be with him, knowing that he would likely die that day. And he said, "No, please, no. I need to be alone." And I felt guilty and terrible about leaving him alone, but you're reminding me that this was his lifestyle and his choice. His whole life had been to be a solo wanderer on his own. And why wouldn't his journey into death be similar to that? And so, I realized it was important to honor that and allow him to be alone when he died.
You got it. Many people choose to die as they lived, right? And that can be very challenging when we're trying to provide the best kind of care for people. But, it goes back to what we were talking about before. Too often the palliative care community has centered what we do around going into communities that don't often have access to palliative care and saying, hey, this is how we do things like us. And that does not work for structurally vulnerable populations like people experiencing homelessness or communities who've experienced trauma at the hands of institutions. What we must do is get in these communities, work with those who have been working with these communities. So that would be, respite shelters, drop-ins, other healthcare workers who have done excellent work over the years and decades to support people experiencing homelessness, and inspire, program development that is relational, that is connected, and that builds off the amazing work that has been done.
Yeah. Oh, it's so inspiring, and I'm curious, knowing that this program started in Canada, where you have a national healthcare system. Have you seen anyone replicate it here in the U.S., where we do not have national healthcare and we have a very fragmented healthcare system? Have you seen it work here?
Yeah, so whenever I'm in this conversation with American colleagues or colleagues around the world who have different health systems in their respective countries, the PEACH program is an example of why Medicare is important, right? I don't know that without a single payer system that we would be able to do the work we do through the PEACH program. Healthcare for all is an important discussion point. Healthcare should not be a publicly traded commodity or good. It is a human right, and I think it often boils down to whether people agree with that or not, right? And those who think it's not a human right, may not agree in a single payer system. But suffice it to say, the Canadian healthcare system and the way we are established has allowed us to build programs like the PEACH program to be able to meet people's needs. We have seen pockets of excellence outside of Canada. including in Seattle, Brisbane, Australia. We've heard of colleagues in Portland, in New York, and in LA who are doing this work and are trying to build programming. But we hear that given the differences in the way the healthcare system is structured and funded, this can be challenging. We are excited also to see colleagues in London, in the United Kingdom, doing this work, and who are connected to our family of programs here in Canada, which include Victoria, British Columbia, Edmonton, Alberta, Calgary, Alberta, and our program in Toronto, Ontario, which are kind of really trying to galvanize and develop this international community. So the international community is small but mighty and definitely growing.
So it sounds like it can be done if there's a will to do it. And I know this somewhat because I've been involved twice in clinics that were, one was in a shelter for women and children who were victims of domestic violence. And another was a community clinic for low income uninsured people. In both cases, we relied heavily on volunteers and donations. So we had to do a lot of fundraising in the community, but it actually worked well as a community project when we were able to educate our entire community and say, we're trying to help our vulnerable population and we need financial support from everyone in the community. We need to get buy-in from the community. So I have seen that work here in the US, but as you said, it's different in every place. Every place is trying to offer this. It will be a different arrangement financially, I'm sure, based on whatever's available.
Yeah. And, kudos to communities and people, like yourselves who do this work. I think that's really important. But at a system level, should it be really up to like Band-Aid solutions and charity to be solving these kinds of issues? If we really, value every human life in our communities, if healthcare is truly a human right and palliative care is a human right too, then we shouldn't have to resort to charitable initiatives. There should be, a system that ensures that people don't fall through their gaps. And I think we're starting to get a little political in this conversation, but inherently these conversations are political. We should not shy away from them, right? The result is that, if you don't have sustaining developed systems that support people who fall through the cracks, is that the disparity gap gets wider and wider. And I think it behooves an even bigger conversation is that I think it's a sad state of affairs that the Peach program and other programs like it even need to exist. Homelessness is a human-made problem that started in the Reagan era and trickle-down economics and has worsened over several decades. Our neoliberalist ideas and neo-capitalism has made us believe that homelessness is just part of life and has to exist, but it actually doesn't. And there are numerous studies around the world that have shown that we can actually end homelessness through strategies like Housing First, which aims to give people a home rather than make people jump through several hoops to get homes. And we have the research to show that it works. It's even more cost effective. It's cheaper. People go to the hospital less. People deal with the police less. And one of the largest studies on ending homelessness in the world was done in Canada called the At Home Chez Soi, that's the French name, demonstration project, which ran from 2014 to 2017, and it was a $110 million study that looked at this question, and it showed, for example, in the population with severe mental illness, that for every dollar we put into housing, we get $1.87 back. So it's better for people who experience homelessness to give them housing. It's cheaper for our communities to just give people housing, and it's the right thing to do. So I think these conversations really can't stand in a static space of accepting homelessness in our communities. We need to talk about ending homelessness in our communities.
Yes, absolutely. It's an interesting dilemma in terms of providing the care that's needed while at the same time pointing out that it shouldn't be needed. It
Yes.
should be this way. But meanwhile, here we are trying to take care of the people right now who need the care. And I was going to say, even, if for people who feel concerned about, what are your politics? Like, throw politics out. The day I decided I wanted to be a doctor, it was so that I could take care of everyone and anyone who needed care. There was no thought in my mind whatsoever that I would pick and choose patients based on who had insurance coverage or who had enough money to pay me for what I did. And, for me, my entire mission as a doctor is I want to care for anyone, and anyone who needs help is someone who's eligible for my care as far as I'm concerned. And it feels to me like our entire medical system should have that same motivation.
I totally agree with you. And I think this is an area of discourse in the United States that I see, swinging like a like a pendulum constantly, right? Not to say that Canada's healthcare system is perfect. We are the most one of the most Americanized universal healthcare systems in the world. People often think all of our healthcare systems are, covered or free. They're not really free. We pay for them in our taxes, but it's actually just access to medical care that's covered. Pharmacare, so medications are not covered. Eye care is not covered. Dental care is not covered. The actual full vision of what Medicare was supposed to be was, from the 1960s. Was actually to cover all these things, and we still don't have that to this day. And actually, just this last week, there was, a lot of debate across Canada around the role of pharmacare, and a very important kind of vote was didn't happen, and we're continuing to wait for pharmacare to actually be a reality in Canada. It's quite contentious. Just to say that there's no panacea in these kinds of discussions, and we need to have them a lot more.
Yeah, it's very true. And we need to have the heart and the will to address these problems as a society, as a medical system, and as medical providers too. And I just wonder how many medical providers might be experiencing moral injury sometimes if you're working in an emergency room and you know that this very sick patient is going to be discharged to the streets. I can't imagine how hurtful that might be for some providers who experience it, and they just have to turn away and walk away and ignore that and move on to the next patient.
Oh, absolutely. Really well said. I think, there's huge moral injury. You can be the best, frontline health worker, nurse, healthcare aide, physician, do the best work, for the person in front of you. But like, how do you deal with the fact that you've provided the best care you can, but structurally the system is still putting you in a position where you are discharging this person to the street, and in some cases to their death. Right. And that doesn't get talked about enough, but that's the reality of what's happening. Let's put words to it. I talk to many colleagues who feel, huge moral injury and compassion fatigue in situations like that. And it can be very, very challenging for people, very, very difficult. And so, more than ever, we need to be able to support each other through this and recognize that moral injury is structural. I think too often, so often we're so focused on the clinical care of the person in front of us, and that is important. We need to, hone our skills, but we need to start having political conversations that change the structures around us in our ability to care for people. Why is it the norm that we are discharging, people in emergency departments and hospitals to the street? Well, why is it not the norm that we're discharging them to housing when people obviously do better, feel better, and our society saves more money as a result? These are the kinds of questions we need to be translating to.
Yeah. And I'm curious for you personally, Naheed. I mean, through Peach, you have a great opportunity to help many of these people. You're actually in a position to do something for these people who are suffering on our streets. But do you yourself face times when you feel burnout or compassion fatigue, or even when you feel moral injury, like I wish I could do more and I can't?
All the time. I mean, absolutely. This work is so difficult. We see a lot of death. We see a lot of suffering. The kind of suffering human eyes really shouldn't see in a city like Toronto, Canada, which is a world leading city in many ways and has some of the best healthcare systems to offer. And yet this is happening, right in our backyard. And so there's a significant moral injury, compassion fatigue among our Peach team and the colleagues we work with in our shelter, respite, and drop-in networks that we work in. And that's why there's a lot of grief that happens. And so, since we started the Peach program, we've been running these initiatives called the grief circles. These are our attempts to basically connect with people in the community around, supporting their grief, who have worked with Peach clients who have dealt with serious illnesses or are dying and have died. And so what happens is when a client dies, we descend on a shelter, respite, or drop in wherever the person was, and we form a circle as a team, and we light the flame. We hold a minute of silence, and we remember that person in that minute of silence. And then we cry, we laugh, we tell stories to each other, we support each other through what it's like to grieve. And then at the end of that, that 1 hour, time period, we, hold a minute of silence and blow that candle out, because we'll inherently have to go out and do that all again. And the grief circles started very informal. I've now become formal. We're now doing them on Zoom and virtual because of the need to, continue to support people. We're having more grief circles than ever before, because we're not only dealing with the homelessness crisis, we're dealing with the overdose, death crisis, and the COVID-19 crisis. So we're having more deaths than ever before. But we find the grief circles are an intentional way to hold space for grief, and it makes a big difference to support the people we care for.
I can imagine that every hospital probably around the world right now needs those grief circles, because all of the hospital staffs are experiencing so much more death because of COVID-19, and in some cases, traumatic, painful deaths of people having to die alone in the hospital. I think that grief circle is a really beautiful idea.
Thank you so much. And we understand that addressing grief for health workers is something that's really important, and it has come to light multiple times throughout this pandemic. And so I hope that our experiences with the grief circle will allow us to have more opportunity to leverage, rituals and practices to give people the tools to address their grief, who are working in healthcare, in social care, so that they don't have to grieve as much as they normally do. And we know that these grief circles, by the way, it's just scratching the surface of the grief that people are experiencing, but at least it's something.
Yeah, I've always maintained, well, at least my experience in medical training is that the grief of the providers was never even addressed. It was never even acknowledged that we ourselves might feel grief when our patient dies. And that no one ever talked to me about that or advised me, like, this, you might hurt for a while after your patient dies. You might feel like a failure, or you might feel a loss. And so at least for me, long ago when I was in medical training, like, I feel like every death that providers experience, we go through that all alone, and no one normalizes the fact that it's okay to feel some pain when someone that you cared for dies, and to even discuss it and to offer ways to deal with it. So hopefully we can make some progress and some strides there. And I don't know how it's been. You're much younger than me, so I don't know how grief was addressed for you in training.
Yeah, in many ways it wasn't, and that's the unfortunate part of it. I don't think a lot has changed, and to think that we are leaning on our health workers more than ever before during a pandemic now, and they're dealing with more grief than they did before, and still not being addressed, to me is a real shame. And I wonder, 30, 40 years down the road, how people will look back at this time and think like they didn't even support the health workers with grief. I think it's actually going to be a very different community then than it is now, but it starts with conversations like this, and I think all the way from training, but into practice, you have to support people with grief. And I think sometimes when we talk about grief, we talk about grief, but we don't help people with the tools to be able to address grief. And it's often comes down to critical reflection. It comes down to naming grief and what it is. It comes down to holding space for grief in group settings. And we have found that this is what works. And I'm sure there's more that works. It's just, we're just starting this journey now, I find. And I think we need to share our practices, and we need to name that grief. I got a call from a colleague who's, feeling irritable and sad and upset. And he said, "What do you think is going on?" And I said, "Do you think you're grieving? You're an ICU doctor. You worked, 3 days, in the ICU and had like 10 people die. You might be grieving." And he said, "What? Really? No way." And I said, "I think you're dealing with grief." And he said, "Wow." And it's just like, I have colleagues reaching out to me because I'm a palliative care doctor. They know something's up, but they themselves can't name it. And these are health workers, right? So they said before COVID, for any time one person died, there was 5 people grieving. During COVID, now one person dies, there's 9 people grieving because of the interconnectedness of our grief during this pandemic. So, grief is a real issue, and it's going to affect a huge amount of people, like at a population level. So we need to be thinking about it now and in the future.
Oh, exactly. And if our healthcare workers were already experiencing burnout and compassion fatigue before COVID started, this is going to be a new pandemic. The grief that healthcare providers are facing.
Totally. We have the pandemic of COVID-19, but we have the pandemic of grief. And that's what worries me. Grief is something that really affects people. It can affect your mental health, your physical health. You can end up using a hospital or healthcare more. It affects relationships, productivities. There's lots of reasons to care about grief. And here in Canada, there's an initiative. I encourage people to look it up, called the National Grief Alliance, a group of passionate, palliative care organizations, bereavement organizations, and mental health organizations that have come together to say we need to inspire change around grief, including a federal call to action to better fund research around grief, but also a public awareness campaign so that people understand what grief is, and finally enhancing clinical services for example, counseling or virtual therapy or group settings or individual settings to support people through grief. So the National Grief Alliance is our country's call to action around that, and I suspect this is an international phenomenon that will need a lot of attention.
And when I look at it, it seems to me that grief is the one thing that transcends everything else that divides us. It transcends all the politics and cultural gaps and religious gaps, whatever they are. All of us, we all experience grief, and we're all going through it at a higher degree than ever before now as a result of COVID all around the world. And if we were to focus on, can we come together in our grief, that seems to be a way to find unity with other people, is let's support one another through this time of great grief.
Absolutely. But how do we do that, right? What does that look like? What are the tools? For a lot of people, grief just is like a lofty word, and they can't really point at it. They don't know what to do with it. I think we need to conceptualize it. And I think it's, set at forums like this and platforms like this that you've created, Karen. I think it's like the palliative care community. I think the death community has so much to offer, the bereavement community, the mental health community. This is probably what we have to offer society at the end. I would like to think we're at the end of the pandemic and beyond. After dealing with the pandemic, this is probably our contribution. I really hope that we will step outside of our typical silos in the areas we work in and see addressing grief as a population health intervention that will help people for generations and generations to come.
Yes. Wow. And grief as well, our hidden grief over homelessness and the fact that we haven't been able to solve it, our hidden grief every time we see the pain of someone sitting on the street corner holding up a sign, who hasn't eaten for 3 days, the hidden pain of all of that, and grieving as a society, those that we have let down, that we haven't given the type of compassion and care that they're deserving of. So all of this massive grief, it's kind of all coming to the surface at once here.
For sure. It sure is.
Well, gosh, it's just, we could talk all day, I'm sure. It's been just fascinating for me to learn about Peach. And I admire you so much, I just have to say, because you have actually seen the problem and you've done something about it. You're actively creating change and making a difference. And that's just, it's beautiful. And you're an inspiration to all of us.
Thank you so much, Karen. I really appreciate that. And the admiration is very much mutual. I appreciate, this discussion and the platform you've created and how you've dedicated time and your own being and everything that you are to this work and communicating it to others. I appreciate this conversation today. It meant a lot.
Well, I wanted to ask, you already gave the website, which I'll put in the show notes, where people can learn about Peach. Are you available? Do you do speaking? How can people reach you if they would like to talk to you?
For sure. Yeah. So I'm available on Twitter and Instagram. You can find me at Naheed. That's Naheedd. And on both platforms, my DMs are open. I'm also on Clubhouse at Naheed, Naheedd. And I really look forward to connecting with people. There's a lot of great dialogue that happens about these topics in our communities. And I really look forward to connecting with you all on these platforms.
Yes, and I'll put all those links in the show notes so anyone can go there who wants to figure out how to connect with you, Naheed. So I'm talking with Dr. Naheed Dosani from the Peach program, Palliative Education and Care for the Homeless. And so thank you so much, Naheed, for being with me today. And I hope we have a chance to talk again in the future.
Me as well. Thank you so much for having me on.
All right. Bye-bye.
Bye.
I hope you enjoyed my interview with Dr. Dosani. As probably was obvious from everything I was saying, I'm a huge fan of his work and so admiring of his dedication and devotion to trying to make a difference in the world and also to changing some of the major problems that are ongoing in our healthcare system. And I find it really inspiring to meet someone who's actually doing something, who's an activist, who's making a difference in the world and doing it in such a compassionate and caring way and being of service to others. And I mean it, if I were somewhere in the middle of my career rather than nearing the end of my career, I would want to be out there myself, helping out on the streets to deliver this kind of compassionate care. And I wanted to say one thing that so touched me when Naheed mentioned that he had a colleague who called him and said, who worked in the ICU and said, I'm feeling irritable and, all the time and just, anxious and not doing well. And Naheed said, I think you're grieving. That just touched me deeply because I know that we're all grieving. I know that everyone in healthcare is grieving, and we all need a compassionate friend who will remind us, you know what, you're grieving right now. So stop for a minute, take a look at that, explore those feelings, and let's work on that together. And try to help each other get through some of this grief, because I agree we're headed for a tsunami of grief down the road, another pandemic, when all of this comes to the surface and when we really start to see breakdown because of our inability to deal with grief. So we have to start planning ahead right now and thinking of how are we going to help one another through the grief that this past year has brought to us, and how are we going to watch out for each other, and what kind of programs and rituals and ceremonies might we be able to create together that can help us all come together and grieve our losses. So with that said, remember there's a new episode every Monday, so tune in again. And if you enjoy this podcast, you can go to iTunes or wherever you happen to be listening and leave a review. That's really helpful if you happen to do that. Share it with other people and go to my page at patreon.com/EOLU if you're interested in becoming a monthly supporter. So until next week, remember, we're here for love. So face your fear. Be ready for whatever life brings your way, and love each and every moment of this fleeting and precious life. Bye-bye.